So you as a clinician should know not to investigate so much for a child with cerebral palsy, except that if there are certain markers, the child was very IUGR, you think that there is a chromosomal anomaly associated with the perinatal asphyxia, then you can actually investigate the child. Otherwise, you won't. Similarly, we have to recognize the teratogenic disorders so that you can let there be a history and find out that some of them might recur, some of them might not recur, right? So what is a preconceptional care? So all these things, like there is a history of intellectual disability in a family, there is history of Duchenne muscular dystrophy, there is history of, there are so many causes of hypotonia in the family, other forms of developmental delay in the family. All these things needs to be really sorted out pre-pregnancy. But what we see that obstetricians who will go away after this course, please tell your couple who come to you, some of the couple will come to you for pre-pregnancy counseling, but eventually they tell that अगले बार जब बच्चा होगा ना 16 हफ्ते में जाके एमनियो करा लेना. So that is not the correct thing. You have to get the disease in the family. You have to learn what the disease was there in the family. You have to have a targeted mutation testing prepared for prenatal testing. It takes time. Sometimes you require NGS, sometimes you require to segregate in the family, whether it is coming from the father and mother. So many things are required. Getting a variation in NGS is not good enough evidence to do a prenatal testing, right? So all interventions that aim to identify and modify biomedical, behavioral, and social risks to a woman's health or pregnancy outcome through prevention and management may be considered to encompass preconceptional care. So it has many components like individual responsibility across the lifespan, consumer awareness, preventive visits, intervention for identified risks, interconceptional care between two pre-pregnancy checkup, health insurance coverage for women with low incomes, public health programs and strategies, research and monitoring improvements. So these are 10 recommendations, but there are 4 goals to improve the knowledge and attitudes and behaviors of men and women related to preconceptional care, to assure that all women of childbearing age receive preconceptional care services, which is evidence-based risk screening and health promotion and intervention, reduce risk initiated by a previous adverse pregnancy outcome, and reduce the disparities in adverse pregnancy outcome. So these are overall 4 goals of preconceptional care, but in our country, we are more focused on child marriage than anything else. So who is the target population of preconception care? Exactly. So it comes with from the adolescent, right? Weight, nutrition, correction of anemia. So all of them actually are components of our, they are the target of preconception care. Any woman in reproductive age group, because teratogenic exposure occurs very early in pregnancy, and we never think of that. So in our consequent slides, I will tell you how we miss that. Any couple who seeks advice are target population of preconception care, right? So sometimes we had done thalassemia screening in the school-going children, the children who are above 16, 18 years, so that we can screen their family for anemia, for beta thalassemia, we had done in school-going children as well. So components are very many: contraception and pregnancy planning, age, medical conditions, family history, alcohol and substance abuse, occupation, diet, weight, immunization of the female, especially personal and social factors, and drugs, what medications they use. So we'll concentrate on drugs, and we all start thinking that probably teratogenic things are only drugs, but there are other teratogenic agents as well. So worldwide, about 40% pregnancies are unattended or unplanned. Health promotion, during health promotion, explain the contraceptive use and safety of each, encourage couples to plan pregnancies. And you know what is Pearl index for contraception. So I will not go in details about that. So age is important. You know about elderly, but please don't stigmatize all elderly women. Then there is something to do with paternal age as well, because new mutations for autosomal dominant disorders like Marfan, achondroplasia, EPAT, they occur more often when paternal age is increased. So when shall a woman be screened for Down syndrome or aneuploidies? All women. And now it is the NIPT or NIPS. So medical conditions in mother definitely has some effects. You know, if the mother is infected with a sexually transmitted disease, hepatitis B, so all this will have effect on the pregnancy as well, if not only teratogenic effect. Diabetes mellitus is very, very important. Diabetes mellitus or gestational diabetes, or especially if the mother has diabetes mellitus before that, there can be macrosomia, hypoglycemia in the child, there can be congenital anomalies in the child, and the target glycosylated hemoglobin is 4 to 6%, not beyond 6%. Hypertension, hypothyroidism, and heart disease, these are all medical conditions in the mother which are to be taken care of. So you should remember that if a woman has hypothyroidism, her requirement increases by 50% during pregnancy. So you have to titrate the drug according to her status of TSH and T4. Chronic arthritis, epilepsy, cancer. So I will go through these small things. Phenylketonuria mother, you know that dietary restriction for 3 months preconception and during conception for development of child brain. If the mother has phenylketonuria, you have to take care of that. Medical conditions in the father is not that important, but if the father has diabetes, varicocele, epididymitis, it might have adverse outcome in the pregnancy. So in family history, draw 3-generation pedigree, extend when necessary, look about ethnicity and race, look for consanguinity. Risk of abnormal offspring for marriage between first cousin is 3 to 5%. This we have discussed. And the background risk is 2 to 3%. So remember that if there is consanguinity, if first cousin marry, only there is marginal risk, only 1.5% risk of all genetic disorders or congenital anomalies, right? So please don't stigmatize. Please don't stigmatize consanguinity. So, and don't attribute consanguinity to all genetic disorders. So this is a wrong concept which pediatrician or obstetrician throughout the country does. अच्छा आपस में तो शादी नहीं हुई, तो आपस में शादी होने से भी 1.5% ही बढ़ता है background risk से, right? So you have to remember that considering that level of third cousin or more is remote and not considered to be genetically significant. Most autosomal recessive diseases are not due to consanguinity, but due to chance mating of two unrelated carriers. So please screen all pregnant women or all women who comes for preconceptional care for beta thalassemia. It is easy, 500 to 600 rupees beta thalassemia screening, where we screen by HB electrophoresis, HB variant by electrophoresis, HPLC, sorry. We don't use electrophoresis now, we use HPLC. And RBC indices. So if MCV is low and A2 is more than 3.5, you do mutation testing in, so you screen the other couple and do mutation testing and get them prepared. Similarly, you can also screen for SMA, though SMA is not that available, but if you are working in a private condition, you also please screen for SMA. The SMA carrier screening carrier rate is almost very similar to thalassemia throughout the world. So look for genetic disorders in the family, like developmental delay, intellectual disability, thalassemia, bleeding disorders like hemophilia. It's a fairly treatable disorder. It is very common. Muscle disorders and weakness like Duchenne muscular dystrophy. It is untreatable and it is very difficult to see a mother suffering because her child is getting weaker day by day, and she knows that her child would have respiratory failure and die. Spinal muscular atrophy again is a very common disorder. Malformations, abortions, stillbirths, and neonatal deaths, because there can be chromosomal anomalies. One of the couple might be carrier of a balanced chromosomal translocation. So look for these genetic disorders in the family whenever they come to you. I won't go into details because these are not probably that relevant in our society. Occupation, like those who are working with heavy metal solvents, pesticides, radiation, health workers, doctors and nurses, and school teachers. Why school teachers? Congenital rubella, right? So rubella is childhood infection. So most childhood infections will be picked up by the school teacher during her work, and
even they come with CMV and all.
CMV, parvovirus, exactly. So
Yes, rubella is common.
rubella is very common. Now with rubella vaccine, it has come down probably, but it remains undiagnosed throughout. So food before they think that the couple is ready to take pregnancy, start folic acid, right? So it is preconceptional, periconceptional folic acid. And when they tell that I am pregnant, when she tells that I am pregnant, she is already 6 weeks and neural tube has already started forming, right? So primary prevention is request for 400 micrograms. We give 5 milligram. So giving extra folic acid is probably not that wrong because the extra goes out through urine, reduces NTD risk by at least 70%. Food fortification and all these things has been tried. Iron has to be given after you do a beta thalassemia screening, and it prevents IUGR and prematurity. Iodine is important in our country. So these things are important.
Iodine is not recommended.
No. That iron deficiency is not there because of hypothyroidism. Hypothyroidism so we are here not only thinking of congenital anomalies, not only thinking of genetic disorders, we are thinking it as a whole for the pregnancy. So the mother cannot be underweight and overweight, which is now important for us. You have to remember that the overweight in the mother predisposes to hypertension, diabetes, thromboembolism, increased cesarean section, and NTD. Vaccine, all vaccines as per schedule, MMR, rubella, hepatitis B, tetanus. So rubella is important if they have personal and social factors. So domestic violence is important. 3 to 8% of pregnant women have domestic violence throughout the world. There can be placental abruption, IUGR, prematurity, neonatal death, and suicide. So what are the 3 most essential diseases to keep in mind? For a geneticist? Maybe thalassemia, neural tube defect, and Down syndrome, right? In our country, it is like this. Now we have added spinal muscular atrophy as well because the carrier screening is high and there is a treatment available for that. So why Indians need evaluation for thalassemia? 3 to 4 in 100 Indians are carriers of thalassemia. And you know this belt. So this is neural tube defect, and you know all those things, nuclear translucency screening. Then exposure to teratogens. Teratology is the study of congenital anomalies and their causes. Tradition is that term teratogenic has been used for non-genetic factors that cause birth defects. A teratogen is an agent that can produce a permanent alteration of structure or function when the organism is exposed during embryonic life or fetal life. So 5,000 years ago, Egyptian wall paintings depicted children with birth defects. So it was there, and it could have been due to various causes, genetic or non-genetic. But the first teratogen was described in 1941, and it was congenital rubella. And the person who described it was an ophthalmologist. And before that, all birth defects are considered to be inherited, right? Then in 61 and 62, thalidomide came in picture in a big way. So why thalidomide was used? It was used as a antiemetic or sedative, right? So among all birth defects, 10% are only teratogenic, right? So this is an old study. It still holds true now. You all know that 3% are chromosomal, 8%. Now monogenic has increased slightly beyond 8%. But there 10% are teratogenic, and this 10% is preventable. So if you identify that, it is preventable. So there is no such thing such as a teratogenic effect. Many agents can produce a teratogenic effect under some circumstances. What determines teratogenicity is time, dose, route, and genotype of the organism, right? So the most important is time. So if somebody tells that I had this drug at this time till 2 weeks, it is called all or nothing period. Either the baby will get aborted or nothing will be there, right? Then from 2 weeks to 60 days, around 4.5 or 5 weeks to 11 weeks after last menstrual period, right? She tells that I have missed menstruation now. I had got exposed to this thing just before I missed the menstruation. So probably it will cause all or nothing. Either your baby will get aborted or there will be no effect because organogenesis have not started, right? So around 5 weeks to 11 weeks after LMP, last menstrual period, so that she has just missed her period and till 6 weeks after that, this is the period of organogenesis. And this is the critical period of exposure of teratogens. So if it has got exposed over there, you start thinking what is the dose, what are the effects, whether we can look by ultrasound, this and that, right? So all or nothing period is one damaged cell can be replaced by another, or there will be non-survival, right? Period of organogenesis from 18 to 60 days, like thalidomide embryopathy, classically is described when the woman is exposed between 27 to 40 days to thalidomide. Exposure later in gestation are generally have functional effects and they do not have effects on organogenesis. Like AC inhibitors, they can have the effects on kidney functions. There is some threshold dose for valproate. I will tell you there are some drugs for which we know, some drugs we do not know. A chronic exposure is more important than an acute exposure. If they get exposed once, probably it will not cause much effect. If she is chronically exposed to a drug, it will cause more effect. Then root systemic absorption is very, very important. If there is systemic absorption of the drug, then it will cause phytopathic effects. So installation of methylene blue into amniotic site in twin pregnancies cause intestinal atresia in 20% cases. Previously, this was how twin pregnancies were diagnosed, right? So higher rate of concordance of fetal alcohol syndrome among monozygotic twins. So there is something to do with genotype, and that might result from differences in cell sensitivity, placental transport, metabolism, receptor binding, and distribution. I will tell few during my lecture. So what can be the consequences of exposure? Death or abortion and miscarriage, malformation. There can be just IUGR. There can be functional defects, and there can also be a normal newborn. So remember that all these consequences are there, and you are the expert or you are the person to whom they have come to seek your advice. So give the advice prudently, give it in quite non-ambiguous manner, but remember that don't forget to tell we really do not know the outcome in a great percentage of cases, right? So, and these are the ways, give in percentages. So what are the strategies to learn this teratogenic exposure? The first is alert or astute clinical approach, case report method, animal experiments, and prospective cohort studies. That is after post-marketing. Many drugs which are being seen have no effects after marketing. People can see effects. The alert astute methods are most of the well-established human teratogens are like this. Like the basic principles are qualitatively distinct pattern of congenital anomalies, like congenital rubella presents with triad of not cataract, chorioretinitis or eye anomalies and deafness, right? So there is very distinct pattern of anomalies. Rise in previously unobserved birth defects, like thalidomide, when the drug was introduced, tetraamelia was found. The hypothesis subsequently confirmed by additional cases, biological plausibility, and supportive epidemiological studies. So this is called Shepard criteria, specific requirements for proof of human teratogen, proven exposure to the agent at the critical time, careful delineation of clinical cases, and 3 or more cases of the same condition exposed to that teratogen, right? So this is called Shepherd's criteria. So selected categorized by this type of evidence is alcohol, valproic acid, isotretinoin, warfarin. Based on clinical evidence is methotrexate, D-penicillin. So these are few examples only. Then prospective cohort studies, comparison of malformation in babies of mothers exposed to drug versus mother not exposed. Major studies are CTIS, the California Teratogen Information Service and Clinical Research, and OTIS. So you have websites for that. And in that website, you click and find out whether research has been done on these 2 drugs, whether exposed or non-exposed, and you can get results out of it. You can write down from that. Part of it is free. So agents which has a prospective course study was utilized to provide pregnancy risk was carbamazepine, then hyperthermia, and few other drugs. Example of carbamazepine study in CTIS was 35 live-born children, women exposed to carbamazepine monotherapy. Minor anomalies were seen in quite a good number of children. Major anomaly was lumbosacral minimum analysis. Before this study, carbamazepine was considered to be safe drug. Valproate was never considered to be a safe drug. So this is probably a child with facial anomalies where the mother was exposed to carbamazepine. So there are animal studies which are standard procedures. At least 2 common mammalian laboratories species are to be used before the drug goes through phase 1, phase 2, and phase 3 trial. So at different doses, 2 animals are given once or several successive days during organogenesis, and conventionally 3 doses are administered. This is how animal studies are done. I will not go into the details of animal studies, but there are false positive and false negatives like chlorpheniramine, hydroxyzine. These drugs, when given to animals, has caused teratogenicity, but when inadvertently used in pregnant women has not caused, and they are considered to be safe now. False negatives are these: carbimazole, methimazole. You know that when they were studied in animals, they did not, but in humans, they cause defects. So the categories can be not only drugs, remember that they can be infectious agents, physical agents, drugs and chemicals, and maternal, metabolic, and genetic disorders. You know maternal diabetes, I have talked about phenylketonuria. So these 3 things I will touch up one after the other. So only if intrauterine infection, remember that only if the mother gets infected during pregnancy, the baby might have the infection. These infections are common in population, cause mild and non-specific symptoms, rubella. About half of the cases may get asymptomatic infection. So you might not find the mother with rash. Then toxoplasma, rubella, and CMV are most important. So a question: a woman has history of 3 miscarriages and the couple is frantically asking for the cause and treatment. The obstetrician asked for a TORCH test who has not been exposed to this 14 days ICMR course. There are many positive and negative values. So what is your duty at present? There's some IgG and IgM value. What will you tell? Don't demean your colleague, right? So this is our professional that we will not tell that, but tell that TORCH group of infection does not cause recurrent abortions. So this was a common practice that a woman has recurrent abortions and a obstetrician issues a TORCH. Then for any IgG, IgM, they will start whatever drugs are available like spiramycin and all, right? So remember that TORCH group of infection does not cause recurrent abortions. Once a woman is exposed to one of the, she acquires immunity, except for few, she will acquire immunity. When she has IgG, that means she has been exposed earlier, right? She has already been exposed earlier. So give her confidence that this is not the cause, don't worry. So random test of IgG and IgM without the knowledge of pre-pregnancy IgG values is difficult to interpret. IgM is known to persist for a long time. So always IgM, generally IgM is a recent infection, but remember that it can persist for a long time and may lead to unnecessary investigation of fetus and termination. So before you get any fetopathic effects, please don't ask for termination just because of IgG, IgM. So when to investigate? Agent-specific IgG and IgM during pregnancy, fever with rash or lymphadenopathy. If you get, you will investigate. There is USG defect, a defect in the fetus detectable by USG, which specifically tells that it can be teratogenic due to these infections. Then exposure to known cause of rubella. Example, a pregnant woman expects to an infected child. You get her sample, see whether she is already has IgG. If she has IgG, tell that you are probably protected. Or she develops, and you get another, if she develops IgM, then she might have got exposed. Then you can, she did not have IgG before that, and she gets IgM. So then you start investigation the baby, whether the child can get affected. Then there can be population-based screening programs, but not considered to be cost-effective. So fetal toxoplasma, you get calcifications like this. To suspect infection in mother, where there is fever with lymphadenopathy, there is ventriculomegaly or intracranial calcification in the fetus. Then in the first trimester, fetal, if there is fetal death, if chorioretinitis is found in the baby after birth, intercerebral calcification, hepatosplenomegaly. So all these are features of toxoplasmosis. In the third trimester, more than 90% are asymptomatic. That means the mother gets exposed in the third trimester. Most of them are asymptomatic. So remove panic from the mother or from the family. So fetal toxoplasmosis can be diagnosed by specific IgM in the mother, documenting conversion of seronegative to seropositive, and USG showing major abnormalities. Diagnosis in fetal infection can be done by fetal cord blood sampling, and a combination of test of IgG, IgM, abnormal levels of liver enzymes in the fetus, thrombocytopenia, DNA diagnosis by PCR-based methods, and isolation of parasites by inoculation into mice. So all this requires a real for toxoplasma, but remember that even if the baby is exposed to toxoplasma, he or she might not have fetopathic effects. So if there is maternal infection is confirmed, then only you give spiramycin. Don't give spiramycin just like that. And after confirmation of fetal infection, you can give sulfonamide and pyrimethamine are added to the regime of spiramycin, and follow-up scanning and neonatal screening is done. Confirmation of fetal infection does not give any idea about possibility of fetal effects and their severity. So remember that. So remove panic from them. So these are the various doses. You can get it easily. Whether when maternal infection is confirmed, how you give spiramycin. When fetal infection is confirmed, you add on these drugs. And congenital toxoplasmosis in neonate, we give pyrimethamine and sulfadiazine till 6 to 24 months of age. So congenital lobella, classic triads are cataract or retinal heart defects and sensory neural deafness. 5 to 12 weeks, severe defects, spontaneous abortions can be there. So this is one child which I have seen. The mother was infected around 13 to 15 weeks. So if the mother gets infected by rubella and we have confirmed, only 50%, 15% get infected. The babies get infected and there can be retinopathy or deafness. So after 17 to 20 weeks, rarely serious sequelae will be there. So if the mother gets infected after 20 weeks, tell that serious sequelae is rare in your baby. So maternal diagnosis again by seroconversion, significance rise antibody titer, and by detection of rubella specific. So a pregnant woman is exposed to a child with rubella, and the nearby physician has asked her to take rubella vaccine. What do you suggest? And she had taken the vaccine and came to you. No, she was exposed to rubella, she was pregnant, and the physician has given her rubella vaccine. Then she came to you, then she has Googled or learned from another person that rubella vaccine should not be given during pregnancy. Exactly. So if a pregnant woman is exposed to case of rubella, develops fever with rash, test for IgG for rubella immediately. If positive, she is not at risk developing rubella. If negative, repeat after 10 days. Development of IgG and IgM confirm rubella infection. Fetus is at risk of getting the infection. If the fever has rubella, if the mother is exposed to rubella and gets the symptoms. So prenatal diagnosis is done by measurement of rubella specific IgM. After 22 weeks, isolation of virus from amniotic fluid, detection of virus specific antigens, just like toxoplasma. So confirmation of fetal infection does not give any idea. So remember that only 15% gets that triad of rubella. There is no treatment of fetal rubella, so there is no point giving spiramycin, pyrimethamine, all these things. Recurrence of rubella is almost unknown in next pregnancy. So rubella vaccine should not be given during pregnancy because they are live vaccines. But if they are inadvertently exposed to rubella vaccine, there is no phytopathic effect. So remove any form of doubt. So a couple was planning pregnancy. The wife got vaccinated with rubella vaccine. She found that she has already pregnant. What do you suggest? So rubella vaccine should not be given during pregnancy. If it is given inadvertently, no phytopathic effect has been seen, right? So this is the dictum. So CMV is one which can be recurrent and generally it occurs to women who has some form of immunodeficiency, probably renal transplant or something. So primary recurrent maternal infections can be there. About 40% pass the virus to the fetus. Symptomatic infection only occurs in 10% of the infected fetus. So CMV is a very common infection, but only 10% of the fetuses will have the phytopathic effects. Most infected infants develop normally. So CMV again can be detected in the fetus in various ways, as I have told you, for rubella and toxoplasma. So what are the differential diagnoses? Epidermolysis bullosa should be the first, right? Newborn is born like this. Aplasia cutis, focal dermal hypoplasia, or neonatal lupus. So this is a baby which I had seen because I take this ICMR course. I could recognize. I had sent to my wife. She is the dermatologist. Cicatricial skin lesion due to a teratogen. Varicella, perfect. So then my wife was prudent enough to get these pictures of the hand, and it was of the foot. So you can.
So this was varicella.
Yes. So this was varicella, and had it been epidermolysis bullosa, the child would have got all over the body, and bullous lesion will keep on occurring, right? So this is a 9 months or 10 months old baby who had this cicatricial skin lesion, developmentally normal. So this is congenital varicella, right? So and this is after the newborn. So she got the picture of the newborn. So this is congenital varicella or chickenpox. So maternal varicella during first 20 weeks of pregnancy can give rise to congenital varicella syndrome. So defects in congenital varicella syndrome is cicatricial skin rash, scarring skin rash, especially in the limbs, right? So this is very, very common. Then hypoplasia and bone and muscle of the limb, which this baby also had. There can be cataract, microphthalmia, chorioretinitis. There can be neurological abnormalities in very small percentage. But the classical is cicatricial skin lesion in limbs. So risk is 3 to 4% during first 20 weeks. Again, remember that all teratogens, the risk does not cross beyond 15-20%. So please don't ask all pregnant women to abort a pregnancy if there is no phytopathic effects, which you can. After 20 weeks of gestation, congenital infection is not associated with embryopathy, but the baby might have respiratory distress after birth, just pneumonia, varicella pneumonia after birth. So major abnormalities are when they are exposed before 20 weeks, are limb hypoplasia, cranial deformities can be excluded by ultrasound, but cicatricial skin rash you won't be able to find by ultrasound. Herpes zoster in pregnancy is innocuous. It has got no risk to the fetus. So drugs, we all know, infants with limb anomalies. So this is, so we never see this. So these are all historical pictures. So this is thalidomide. So thalidomide was used as an antiemetic or sedative. it was first developed as an anticonvulsant. Now thalidomide is being used for various others, like in thalassemia, intermediate, also people are using thalidomide. It has got some effects on the immunological system. So critical age, gestational critical time is that period of organogenesis, which I have told 40-44 days is the most sensitive. So the hypothesis is inhibits angiogenesis, downregulates some adhesion receptors and reduces phagocytosis by polymorphonuclear cells. So it was approved by FDA in 1998. Current indications are erythema nodosum leprosum with disfiguring lesions. Thalidomide is still used, but there must be a steps system for thalidomide education prescription safety program. So we have to know whether that person might get pregnant before you start thalidomide. Then you have to give contraception for the couple if you use thalidomide. So these are the from tragedy to promise. This is what the drug company has actually provided, that thalidomide is definitely has teratogenic effect. There is no doubt about it. It is proven beyond doubt, but it has got some effects as well, good effects as well. Similarly, another drug was isotretinoin, which has been under this type of program, that when a dermatologist uses isotretinoin, they will make sure that she is not pregnant if she is in childbearing age. Then they will use contraception if they are in childbearing age. They have to get things written, get consent for use of isotretinoin as well. So this is called a pregnancy prevention program by the company Roche, who has actually introduced isotretinoin for them. So 2 negative urine or serum pregnancy tests before starting Accutane, 2 reliable forms of contraception for at least 1 month before taking during treatment and 1 month after discontinuing Accutane, even when one of the forms of contraception is hormonal. Only receive a 30-day supply of medication, refill consistent upon repeat negative pregnancy test. So these are prerequisites for isotretinoin therapy. So study about drugs during pregnancy can be there. You can get through all this. So currently undetermined are 97% drugs are really undetermined. Still, we do not know more than 90% of the drugs, and each drug has some levels. So these are the drugs, and these are the teratogenic effects of various drugs. So for lithium, you know that Epstein anomaly of heart was not correct, right? So which had been stamped to lithium is not correct. There was some problems with the drug company and the regulatory bodies. So somebody has been punished for this. I do not know. But lithium with Epstein anomaly is not there now. And FDA in pregnancy classification, class A, class B, class C, class D, class X. So it has to be written in the drug level. So class A drugs, folic acid, vitamins and thyroid hormones, these are class A drugs. Class B, like presumably safety based on animal studies like amoxicillin. Then these are things which should not never be used, like Accutane or isotretinoin. So these are examples. Many women who are epileptic and or anticonvulsant, there are some things to be considered when they come to you for a preconceptional care. The overall magnitude of risk is 2 to 3 times that of a normal population. Polytherapy is associated with increased risk. Many adversely affect the postnatal cognitive development of the fetus, even if there is no congenital anomaly. So this is a baby with limb defect, some thin upper lip. So radial ray defect. Differential diagnosis. Americanian metophthic reach. Not very good picture, but you can see, so Holt-Oram tar, all these things comes into mind. But while we take pedigree and we take drug history, so mother was on valproate, right? So this is fetal valproate syndrome. They might also see there's a long philtrum. You know, the philtrum is the space between the nose and the upper lip, thin upper lip. So these are classical features of valproate. You can also have neural tube defect, but this limb defect is very classical of valproate, if not various other causes of radial ray defect. So the risk of spina bifida is around 2%. So there is a dose of valproate. So valproate, if given more than 1000 milligrams per day, might cause this birth defect. So if at all valproate has to be used, if it is absolutely essential, use another drug, use valproate in lower levels to prevent this defect. And valproate has lot of phytopathic risks, and probably this is the one drug which should be avoided in pregnancy. Try any other drug but valproate. So you know that fetal hydrocton, phenytoin, there are certain phytopathic effects. About 10% of infant born to epileptic woman treated with phenytoin will have mid-phase hypoplasia, low nasal breathe, this and that. And carbamazepine, I have already shown you a picture. There can be spina bifida in 1%. Lamotrigine, again, there is increased neural tube defect. Don't think that lamotrigine is safe. How to choose anticonvulsants? So there should be a preconceptional counseling. Primary consideration is essential control of symptoms. If the mother gets an epileptic fit during pregnancy, that can be very, very detrimental to the pregnancy outcome. So our primary consideration is control of symptoms. The most common treatment strategy is appropriate drug for the seizures as monotherapy, right? In the lowest effective dose. So you have to titrate it before pregnancy. She remains seizure free for quite some time, maybe 6 months or more, and then she starts pregnancy. So that is the best way to go about it. So valproate acid should be avoided if possible in all possible effects. The later information should be sought. Any major change in the treatment should be completed before conception. Regular monitoring of drug level is required for lamotrigine. The couple should be counseled about risk, prophylactic treatment with folic acid, and importance of early detection of any anomalies by ultrasound. Because many of these anticonvulsants have antifolate effects. So anyway, you have to start folic acid. So newer AEDs are supposed to be safe. So lamotrigine with anencephaly has been, so these are just a case reports. So we really do not know whether this happens or not. So for this, any association between these drugs needs to be reported with time. So I have already shown you this. The baby had. This is Strider, right? Difficulty in inspiration. This is Strider. So what defect do you see in the baby? Very small nose. There is no nasal bridge, right? So this is then when they called me in the newborn, I had asked for an X-ray. And what is this? Stippled, yes, chondrodysplasia punctata. With this, so this is fetal warfarin. Mother had cardiac disease, prosthetic valve. She was on warfarin, right? So this is very classical of fetal warfarin. You see a nose like this, and the stridor is because of very difficult passage through the nostril and upper airway. So this is another baby with same disorder, fetal warfarin, who has come to us late in pregnancy. So thromboembolic prophylaxis of women with mechanical heart valve was best achieved by warfarin group. Fetal effects of warfarin is aplasia of nasal bone and punctate calcification of epiphysis, that is classical. There is increased risk of CNS malformations, may be related to hemorrhagic complications which occur in the fetus due to the use of warfarin in the mother. Again, but you remember that chondrodysplasia punctata can be due to various causes, not only fetal warfarin, like chromosomal anomalies. Chondrodysplasia punctata per se is a associated rhizomalia. So there are genetic defects which might give rise. And again, mid-phase hypoplasia can be due to, this is a normal baby, normal infant who has mid-phase hypoplasia. We call this binder phases. Not always it is associated with anomalies, but you have to remember that when they persist and there is a history of warfarin use in the mother, tell that there can be. So balancing maternal morbidity and mortality versus fetal loss and embryopathy is very, very important. So risk of fetopathic effects is 6%. Even if the mother uses warfarin, the risk of fetopathic effects is 6%, not 100%, not 50%. It is replaced by heparin between 6 to 12 weeks. And if it is done, then there is negligible fetopathic effects. Again, this is the time of organogenesis. So this time you need to admit the mother and give, because while you give heparin, you have to monitor. So there is, but during this period, if you replace warfarin and the mother was on warfarin for quite long, and when you take out warfarin, with the use of warfarin throughout pregnancy is 4%, and it increases with the use of heparin. So risk of valve thrombosis increases. The use of low dose heparin is definitely inadequate. So you have to use adequate dose of heparin during this period of organogenesis to prevent fetopathic effects of warfarin. So variability of warfarin doses, before 2000, it was age, sex, BMI, smoking, vitamin K intake, and concomitant drug therapy. Now what we do, you can do this to genes, and there is 35 to 50% variability in warfarin doses. Whether this polymorphism is there or not, you can change the dose of warfarin according to that. So summary of drugs: antiepileptic, never use valproate, try to take out valproate, but remember that control of epilepsy in the mother is the most important thing. Anticoagulant thing, remember warfarin, but you also remember that fetopathic effects is only there in 6%. And if you take out warfarin, there is very high chance of thrombotic heart valve. So it needs to be weighed. Maybe it can be taken out at 6 to 12 weeks and replaced by heparin. Then immunosuppressants like cyclophosphamide methotrexate should be avoided. In cosmetic, retinic acid should be avoided. So radiation question: a 5-year-old child is admitted with non-resolving pneumonia. Baby, his mother is accompanying him. The mother got exposed twice to X-rays during taking X-rays because the child has pneumonia, and the mother was sitting with the child. The child became well after 2 weeks of treatment. The mother came asking to you whether to abort the baby she is carrying for last 3 months. She got exposed to X-rays twice. Okay, perfect. So nothing. So malformation has a threshold. Here again, threshold comes. That is 100 milligauss or higher. Typically associated with central nervous system problems. Fetal doses of 100 milligauss are not reached even with 3 pelvic CT scans, right? So inadvertently, the mother had a fall and got an X-ray done. The mother is pregnant. Please don't tell her to abort the baby. You can just follow up. These levels can be reached with fibroscopically guided interventions and radiotherapy. So radiation exposure to X-rays is not that teratogenic what we think, what we had a notion before. So it depends upon as those stage of pregnancy. Radiation risks are most significant again during organogenesis, as we have already told. They might have fetopathic effect. Fetal doses range is 100 milligauss. Some reduction of IQ might be there, but there might not be any visible fetopathic effects. Fetal dose range of 1000 milligauss can result in severe mental distress microcephaly. So you can see that what amount of dose is required. It is very, very high. So counseling: thousands of pregnant women exposed to ionizing radiation. Lack of knowledge is responsible for great anxiety and probability in unnecessary termination. Most patient radiation exposure is medically appropriate and the radiation risk of fetus is minimal. Ultrasound examination, microwaves or computer terminals are harmless. So they will tell that I am getting ultrasound so many times, will it cause a defect to the fetus? No. And probably that amount of radiation we also get exposed while we travel in an aircraft. So 3 possible clinical settings during evaluation of patient, usually a child, when the medical history or physical suggests the possibility of teratogenic effect. The fetal valproate, I have shown you. The child came for evaluation and we have found out that the mother is epileptic. So in our next pregnancy, we will be able to correct. We'll take out valproate, we'll give her another drug in the lowest possible dose. Will come, we'll see that she is seizure free for 6 months, then we'll start folic acid and she will become pregnant. Counseling will help to provide optimal care to the child and potential prevention of similar problems in future. When the couple comes, second, for genetic counseling, pre-conceptional counseling for possible teratogenic like the mother is already on anticonvulsant drugs, or the mother is already on warfarin for prosthetic heart valves. And third is accidental exposure. So this is probably very common and concern me whether she should terminate the pregnancy, consider prenatal testing, and or accept the additional risk associated with. So these are the three situations. Sometimes we do not know, like I have seen this baby, the mother had some psychiatric problem and she was on FOETUS. FOETUS is supposed to cause, probably the baby was very short but intellectually normal. So we do not know, and we are in search. So these are the various databases where you can search for various drugs, their exposure during pregnancy, what can be the outcome. There are studies. So the website looks like this. So you get a summary of a drug from there, which is free. Then part of it might be, so this is OTIS, another way where you can get these drugs. So take home is the alert attitude clinical approach is important to recognize teratogenicity. Screen for teratogen use before and during pregnancy. Risk-benefit ratio need to be considered for antiepileptics. Lack of knowledge may lead to under-treatment and accidental exposure. Find the risk, take correct decision, help from the literature, what is available. Preconception care is essential intervention. Watch out for teratogens. Look for genetic disorders in the family in preconception care. Never stigmatize consanguinity, X-linked disorder, or advanced maternal age. Preconception care cannot guarantee uncomplicated pregnancy. So see, they are seeing here another flight which is coming from the outside. So there are uncertain factors we cannot, yet control will always remain.